Oh, nice to meet you. My name is Dr. Hyang-yeon Lee, and I'm the director of Michigan Dental Clinic. I will talk about immediate placement after extraction today. I graduated from Dental College of Busan National University in Busan in 1988 and studied at the Implant Clinic of OSU in the USA in 1999. I am the director in the DO Navi Planning Center as a clinical consulting doctor. I have been a dentist for the last 30 years. I am also the representative director of Michigan Dental Clinic. If you have any questions on the contents of my lecture, please send them through the email address below, and I will reply as soon as possible. I will explain the advantages of immediate placement after extraction first. Immediate placement after extraction refers to placing implant in the location where the tooth has just been extracted. I will examine the advantages of immediate placement after extraction from various aspects. First, patients are highly satisfied with the aesthetic aspect of immediate placement after extraction because implant is placed along with temporary prosthesis after extraction at the same time. This is a case where the patient needs immediate placement after extraction due to severe inflammation in the mandibular anterior tooth. If we were to simply extract the tooth and wait until the extracted part is healed, we will need to either install removable prosthesis to the anterior tooth or leave it blank. This will cause the patient to experience extensive inconveniences. However, placing implant immediately after extraction with GBR and loading temporary prosthesis can be an aesthetically satisfying procedure for the patient because the temporary prosthesis is inserted right after the tooth has been extracted. This is a photo after completion of the procedure. Here is a photo where, in spite of the severe inflammation, the implant was placed with GBR after tooth extraction. Second is that the overall time decreased because implant was placed immediately after extraction without any healing time. That is, we can get more treatment time for other patients. Third is that you don't need to make additional incision since implant is placed in the spot where the tooth was extracted. This is a huge merit for the patients. It can also be a significant advantage from the surgeon's perspective. This is the same context as the number 2 I explained above. You don't need to wait for the extraction socket to heal to place the implant. Then you can prevent bone absorption by placing implant immediately after. It is possible to prevent excessive absorption. In particular, bundle bone of anterior tooth can be absorbed easily because after the extraction, the blood does not spread around that area. It is possible to prevent the absorption of this bundle bone by performing immediate placement after extraction. As it can be seen in this patient also, if this tooth is extracted, substantial portion of the remaining bone tissues would have been absorbed along with the tissues of inflammation. It can be seen that performing GBR after the tooth extraction prevents excessive absorption of these bone tissues. In particular, in the case of anterior tooth, bundle bone will be left behind if tooth is extracted. This bundle bone has a tendency of being absorbed easily since blood is not being supplied harmoniously. The biggest advantage of immediate placement after extraction is that you can maintain the height of the bone at the level of the natural tooth height by preventing the absorption of bundle bone through implant placement after GBR placing. Then, it is possible to prevent absorption of periodontal tissues along with it. In the case of this patient, it is inevitable that the periodontal tissues will shrink in accordance with the direction of the bone absorption when tooth is extracted due to severe inflammation. It is possible to prevent absorption of periodontal tissues that assists bone with inflammation by placing implants immediately after extraction. This is the photo of completed procedure. You can see here that there is no major difference in the periodontal tissues prior to and after the tooth extraction. If implant is placed immediately after the extraction, it is also possible to prevent absorption of periodontal tissues. Another major advantage is that it is possible to place implant in the tooth extraction socket since implant is placed immediately after the tooth extraction. For this patient, teeth number 12, number 21, and number 22 will be extracted and implant will be placed. This is the photo immediately after the teeth extraction. By placing implant into these tooth extraction socket immediately, it is possible to produce prosthesis or maxilla-mandibular tooth relationship very naturally in the future. This is a photo of a patient who had the teeth number 12, number 21, number 22, and 24 extracted and implant placed in the extraction sockets immediately thereafter. Being able to place in the tooth extraction socket can be more advantageous in terms of various occlusal surface or aesthetics. Last, majority of cortical bone is still remaining in the tooth extraction socket. Although it may seem that there would be inadequate bone since it is a tooth extraction socket, it is possible to use this cortical bone for initial fixation. Cortical bone still remains underneath the tooth extraction socket in most cases for its use in initial fixation of the implant. Then, is immediate placement after extraction possible in all cases? Let's check if there are precautions that need to be exercised. Problems in immediate placement after tooth extraction can be divided largely into 3 issues. First is the problem arising from the configuration of the tooth extraction socket. Second is the problem arising from the difference in the sizes of extraction socket and implant. Third is the periodontal or periapical lesion in its surrounding. These 3 issues can become major problems. The problem arising from the configuration of the tooth extraction socket can influence the initial fixation or direction of implant. Second, the gap arising from the difference in the sizes of tooth extraction socket and implant can be seen as 2 types. There could be difference in the soft tissue and bone. The third is the inflammation of periodontal or periapical lesion. These 3 issues can be deemed as the biggest problems in the immediate placement after tooth extraction. We will now look at how these problems can be solved. In the case of such simple tooth extraction, that is, if the size and direction of the implant are similar, there also is not that much shortage of periodontal tissues. Accordingly, there is no problem whatsoever in placing the implant immediately after extracting the tooth. However, if the implant ends up being placed in wrong direction instead of the desired direction due to too many roots, or the implant can be placed in the undesired direction because the root is not deviated to the desired direction even if there is only a single root. That is, implant can be placed into the direction you do not desire due to the configuration of the tooth extraction socket. How can this be solved? This is the reason for the use of surgical guide such as DioNavi, which is produced very accurately. We will see how surgical guides such as DioNavi can enable the setting of the direction and initial fixation of implant in the manner you want. Metal sleeve in the surgical guide of DioNavi plays a very important role. Drill first in the desired direction when performing surgery without a guide. However, as you drill, there is extensive tendency of the drill slipping towards the lowest section of the tooth extraction socket to cause the implant to be placed in a wrong direction, if you are not careful. In addition, even if you drilled in the desired direction the first time, the implant can be placed in the opposite direction if you drill excessively in the opposite direction to prevent it from slipping towards the tooth extraction socket. However, the sleeve maintains the direction of the drill, so it is possible to place the implant in the direction you wish. That otherwise has tendency of slipping towards the tooth extraction socket. This is the tooth extraction socket. If the guide is inserted, this sleeve holds onto the drill to enable you to drill for the implant in the direction you desire. That is, problem arising from the configuration of the tooth extraction socket can be solved by using a surgical guide that is made accurately and precisely. Second is the problem arising from the gap between the tooth extraction socket and the implant. First is due to tooth extraction with lack of soft tissue. And second is that there can be gap between the implant and tooth extraction socket if there is severe bone resorption or if the tooth is very large. Lack of soft tissue can be covered by using PRF and bone-forming screw or healing abutment. Absorbable membrane can also be used instead of PRF. However, PRF is substantially more convenient to use. If there is severe bone absorption or very large tooth was extracted, GBR can be applied for the gap. As such, if there is no difference in the sizes of the implant and tooth extraction socket, and there is no particular shortage of soft tissue in the gum, there is no major problem. However, if you remove all inflammatory tissues after the tooth extraction, there would be severe shortage of soft tissue. If implant is placed in this condition, debris or foreign matters will enter the gap between the implant and the tooth extraction socket, thereby resulting in implant failure. Therefore, it is necessary to cover the gap. If very large tooth or tooth with severe inflammation is extracted, there exists a large gap between the implant and tooth extraction socket. Producing PRF by collecting autologous blood through the use of centrifugation will be very useful in covering the shortage in soft tissues. It is also possible to cover the inadequate soft tissues by using healing abutment if the size of the area is small and bone-forming screw if the size of the area is large. In addition, GBR can be executed for the cavity with inadequate bone due to severe bone absorption. That is, the second problem of the gap between the tooth extraction socket and implant can be solved by using PRF and bone-forming screw or healing abutment for the area with inadequate soft tissues. GBR can be used for locations with severe bone absorption. The problem of the periodontal or periapical lesion inflammation in a way can be the biggest reason why we often want to avoid immediate placement after extraction. This is because the implant can be a failure due to bacteria if there is inflammation regardless of how good the direction is and how the implant is placed. However, if you look at globally renowned journals during the period of 2010 to 2015, even when performing immediate placement after extraction of tooth with severe inflammation, it is possible to perform debridement and curettage perfectly, and if there is severe inflammation, administer additional antibiotics and perform bone transplant if needed. If you perform perfect debridement and GBR and administer antibiotics systematically, and if care is given well prior to and after the procedure, there is no major difference in the success rate whether there is or is no inflammation. Trying to completely exterminate the bacteria that causes inflammation. First, perfectly perform curettage and dress physically. Second, administer sufficient antibiotics systematically. Third, if GBR is performed, there would be no problem whatsoever with the immediate placement after the extraction with inflammation. Fundamental rule is important for the successful technique of immediate placement after extraction. You must use well-disinfected instruments, keep the operating room clean, and wear a sterilized gown. Second is that the perfect handling of immediate placement after extraction is important. You must perfectly handle tooth extraction socket according to the tooth extraction socket preservation technique. Another enormously important aspect is that you must use a surgical guide. In particular, you must use a precisely made surgical guide such as DO-Navi and use sufficient antibiotics. If the inflammation is severe depending on the case, it is advisable to perform GBR first before placing implant. Then I will show you the mandibular molar part among the immediate placement after extraction. Molar tooth is extracted. After extracting the molar tooth and completely removing inflammation, we end up with huge tooth extraction socket. Precaution to be taken at this time is that you must not remove the soft tissue on the buccal or lingual side, regardless of how extensive the inflammation is. Soft tissues are maintained because of the teeth even if the bone at the bottom has dissolved extensively. Since the bone and implant will be covered by using this soft tissue, you must not remove these soft tissues and must maintain them. For this patient, number 6 and number 7 mandibular teeth on the right with severe inflammation will be extracted and implant will be placed. Although the bone absorption is extremely severe under the X-ray, it can be seen that the gum is intact and raised to cervical when examined clinically. Since GBR will be performed by using this gum, which is raised to the cervical, this gum must not be removed. Tooth is extracted and flabby gum is remaining. Inflammation was removed thoroughly. Since it is not easy to show the image of removing inflammation for the molar tooth, I will show the video of that for anterior tooth. If you see this patient, there is extremely severe inflammation and the bone absorption has extended to the lower portion of tooth apex. It has dissolved extensively in the buccal side and bone remains only at the top of the gum with almost no bone at the bottom of the gum. Tooth is extracted. After the tooth extraction, inflammation lumps are being scraped off. Scraping alone may not be enough to remove all the inflammation lumps. In such case, it is possible to remove inflammation with a Kelly. Since they are difficult to remove, rip them off with a Kelly and thoroughly use curette on the inflammation tissues stuck on the bottom inside of the bone tooth extraction socket. However, what is important is that you will be able to see the gum without the attachment of bone due to full absorption of bone on the buccal side if you look there. If the gum on the buccal side is removed due to the presence of inflammation, the immediate placement after extraction will fail. You must never remove the gum. You need to thoroughly remove only the inflammation tissues in the tooth extraction socket while leaving the gum on the buccal side intact. There is no bone at all in that section. Wash off. You must check several times for the presence of inflammation. And you must also check whether the guide is fitted well. Since the guide is made prior to the tooth extraction, it is essential that you check whether the guide fits in the tooth. After checking, put doxycycline cotton into the tooth extraction socket until the time of surgery. This is effective in pacifying the bacteria inside the socket to a certain extent. Doxycycline cotton is taken out immediately prior to the surgery. Then I start the surgery. The doxycycline on the cotton ball is the doxycycline that we eat. Loosen the capsule and put doxycycline on the cotton ball that has saline on it and insert it into the tooth extraction socket until the time of surgery. If the tooth extraction socket is large, use a large cotton ball, and if the tooth extraction socket is small, use a small cotton ball. If you use several small cotton balls, there is a possibility that some may remain in the socket. Therefore, it is important to use a single large cotton ball. In addition, prior to performing surgery after taking the doxycycline cotton out and inserting the guide, you must check whether the guide is made properly and whether you can place the implant as you planned by using the guide by taking X-ray image. I am checking by taking X-ray image with a guide seated in the mouth after tooth extraction. If the original offset is 9, then the implant can be placed with offset of 9. However, there are situations in which you need to increase the offset by a stage due to inflammation of the tooth extraction socket getting more severe than what you have planned. You can make such application if you perform immediate placement after extraction extensively. Then you can use longer drill by putting in one more offset than you originally planned. First, check to see if the guide fits well as originally planned. For this patient, implant surgery is commenced after having checked the offset and the length of the implant by inserting the guide and confirmed that everything is all right. In addition, it would be a good idea to think about whether to put the healing abutment later or to put bone-forming screw into the tooth extraction socket. Take out the doxycycline cotton ball. Take it out and then insert the guide to start drilling. First, you must use a drill tube. It is very important since the implant can be placed by drilling the implant in the desired direction with a drill tube. If the tooth extraction socket cavity is not that deep, start with 2.0 by 5 drill. If the tooth extraction socket cavity is too deep because it is too large, 2.0 by 7 drill can be used. 2.0 by 8 by 5 drill can be used first depending on the situation. Insert the drill tube into the guide sleeve and start 2.0 drill. At this time, you must take precaution to ensure that the 2.0 drill should enter the drill tube vertically. Let's take a look. The tooth extraction socket is somewhat different from the direction of placement. However, I put the guide and the drill tube. Drill with 2.0 by 8.5 mm drill. If drilling is performed at low speed, the 2.0 drill may slip due to the bone at the bottom. Then, you won't be able to drill in the direction you want. Therefore, when using 2.0 drill as the first drill, you will be able to drill as planned if you do so at high speed along with irrigation. Using 2.0 drill sequentially and then use 2.7 drill after having taken out the drill tube after sufficient irrigation. If you use 11.5 mm 2.7 drill directly for the implant length that we originally want to place at this time, you will get the problem of the sleeve and drill not making contact. Then there are cases of having tooth extraction socket or hole drilled with 2.0 drill at the bottom of this. However, this drill has higher probability of slipping towards the tooth extraction socket side. This is because the hole is bigger. Therefore, since you will be able to drill in the desired direction if this sleeve does not come in contact, the 2.7 drill, which is the next stage, may not go to the undesired direction. Therefore, you must drill sequentially. Drill by putting in the 2.7 by 8.5 drill first, ensuring that the sleeve is in contact. Then, drill with 2.7 by 10 drill after the sleeve makes contact. In addition, you must drill after contacting the 2.7 by 11.5 drill with the sleeve. In this way, you will be able to drill in the direction you desire. It is the same when using 3.0 drill after having used 2.7 drill. When drilling with 3.0, do so in the order of 8.5 mm, 10 mm, and 11.5 mm. And when drilling with 3.2 drill, do so in the order of 8.5 mm, 10 mm, and 11.5 mm. It is the same for the following stages. It is possible to drill in the desired direction perfectly if you drill in this sequential manner. Never skip drill at first. Do not skip for the accuracy of the drill. After drilling several times immediately after tooth extraction, you can skip if you think it is all right to skip this part. However, the foremost principle is not to skip drill. You must not skip the drill sequence. Drill up to the final drill in accordance to the drill sequence. After drilling, take out the guide and extract tooth before putting the bone into the drilled tooth extraction socket. Put the bone in first regardless of whether the tooth extraction socket is small or large. After putting in sufficient bone, you need to perform final drilling once again. If the bones are still in the tooth extraction socket, they can interfere with the direction of the insertion of the implant. Accordingly, in order to make the hole for the insertion of the implant, it is necessary to perform final drilling once again after having put the guide in following GBR. In this way, if there is dead space that has not been filled with the tooth extraction socket for which GBR is to be performed, bone will enter into such dead space. Then, place the implant now. Precaution to be taken at the time of positioning the implant is to make sure to insert the implant in the direction vertical to the sleeve of the guide. Otherwise, since there is cavity of the tooth extraction socket and the hole you drilled at the bottom, it is possible for the implant to enter into the tooth extraction socket cavity side. Accordingly, the implant will be inserted to a certain extent but abruptly stop without being put in fully. I also have such experience. You will be able to place the implant accurately if you insert the implant into the direction you drilled by keeping the direction of the sleeve and implant placed vertically. Check and remember the offset, and if the offset is 9.0, place the implant to the very bottom and in accordance with the offset amount. This photo was taken immediately after having placed the implant. Check whether sufficient bone has been put into the area around the implant or whether there is inadequate bone, as well as the presence of bone particles in the implant. If bone particles enter inside the implant, they will interfere with mounting of abutment or implant, including healing abutment, customized abutment, and bone-forming screw, etc., which may become the cause of implant failure. Therefore, you must check their presence. If there are bone particles, remove them by using a suction tip. Then, decide whether to put healing abutment or bone-forming screw in depending on the size. If the hole is small, healing abutment can be put in without PRF, and PRF can be mounted on the healing abutment. In other cases, only bone-forming screw can be mounted or by mounting the PRF onto the bone-forming screw. In this case, PRF was mounted on the healing abutment, but it appears that it would have been fine even if PRF was not mounted. This is a case in which PRF was mounted onto bone-forming screw due to significant lack of soft tissues. Mount onto the implant by using healing abutment or bone-forming screw like this. Then you must suture the tooth extraction socket. After the healing abutment or bone-forming screw has been mounted. Although healing abutment is used in majority of mild or moderate cases, healing abutment could be completely covered and can also be exposed. There also are cases in which PRF can be used and need not be used. If the tooth extraction socket is small like this, it is all right not to use PRF. You can use healing abutment or leave it exposed. In addition, if the tooth extraction socket is deep, you can put the healing abutment to the extent of being placed slightly inside. What is important is that you need to suture to prevent the bone in this space between the soft tissue and the abutment does not leak out. If this opens, bone between the implant and tooth extraction socket inside will leak out. Therefore, you need to suture to prevent leakage of the bone particles. Even in this case, this is the photo of PRF on the healing abutment and placed on the implant since it is a bit too small to use bone-forming screw, but slightly too large to use only healing abutment. You need to suture to ensure that bone between the implant and soft tissue does not leak out. It is very useful to use bone-forming screw for molar tooth or large cavity that cannot be covered only with healing abutment. Mount PRF to the bone-forming screw. Make PRF flat like this and place implant by mounting the PRF onto the bone-forming screw. What is important is that this bone-forming screw margin must be inside the tissue. When using this bone-forming screw, this cavity is wide and there is bone at the bottom of the bone-forming screw. As such, you must suture in order for the soft tissue to cover the margin. As shown here, soft tissue covers the bone-forming screw with the bone-forming screw and PRF bound inside. It does not mean full coverage. The outer boundaries must go underneath the soft tissue to ensure that the bone particle inside does not protrude out. It is same for here. This is the state of having performed the procedure after placing the implant by mounting bone-forming screw with PRF. Although healing abutment can be exposed to outside, bone-forming screw must be underneath the tissues. If you see here, it is exposed. However, the outer boundaries must be underneath the soft tissue. In the case of this patient, tooth was extracted and mounting was done with healing abutment. Healing abutment was mounted for the finishing touch because it did not seem necessary to use bone-forming screw since there are sufficient remaining soft tissues. This much bone was removed. And this is the photo of completed procedure. Since this patient displays soft tissues with severe bone absorption, bone-forming screw was used for the finishing touch. This is the final photo after about 8 months. Thank you. Now I will explain the procedure by viewing the video of surgery performed. This is a 63-year-old female patient. These are photos of the frontal view and upper jaw prior to the surgery. Tooth was extracted from this mandibular area and implant will be placed. If you see here, number 5 was just placed, an implant was placed immediately after tooth extraction for number 6. Number 5 has no offset, while number 6 has 10.5. Tooth is extracted and guide is inserted to check the offset. I checked number 45 and number 46 offsets. This is the process of extracting the tooth and inserting the guide. This tooth in the bridge needs to be extracted. When extracting the tooth, it is important not to damage the tissues around the tooth extraction socket. Therefore, extracting the tooth without damaging the tissues around the tooth extraction socket as much as possible by using elevator is one of the factors that would ensure that immediate placement after extraction will be successful. It is advisable to ensure that bone does not flex and to retain the gum as much as possible. When all of these are removed, inflammation becomes visible. Inflammation will be curetted. If you examine the curette closely, it is shaped like a saw-toothed wheel. It is very helpful in scraping out the inflammation tissues. It performs much better than simply rounded curettes. Wash off with saline and check once again. Check whether it is clean, and remove the remaining inflammation tissues. Check whether there are remaining inflammation tissues, and perhaps the process of this curetting could take the longest time in the immediate placement after extraction case. Extract the tooth and check whether the guide matches well by inserting the guide. Then, open the doxycycline capsule of the tooth extraction socket. After having wetted disinfected cotton with saline, wet it again with doxycycline and insert it into the tooth extraction socket. Since I wasn't able to take photo of insertion of doxycycline into this patient, I took photo of another patient for the insertion of doxycycline. Now, wait until the time for surgery. Remove doxycycline immediately before the start of the surgery. Occasionally, when you put the doxycycline cotton balls in by rolling up smaller cotton balls, make sure to count the number of cottons to ensure that every cotton balls that have been placed in are definitely removed. Otherwise, doxycycline cotton remaining in the cavity can become a major problem. Accordingly, it is advisable to use a single large cotton ball as much as possible. Take doxycycline cotton out and insert the guide again to check whether it has been put in its proper place. Then begin implant surgery now. 4.0 by 11.5 implant will be placed for number 45 after having performed tissue punching rather than immediate placement after extraction, since it is a simple guided surgery. I am punching the tissue now. Execute bone flattening drill to the bottom line since the offset is 9.0 millimeters. In the case of simple guide implant surgery like this, you can use 2.0 by 5 drill that makes contact with sleeve without having to use the drill tube. Even if you use this, it is possible to place implants accurately if you keep the direction correct. It is 2.0 by 5 drill for which the drill can come in contact with the sleeve. This is 2.7 by 5 drill. In addition, bone that is drilled out with this drill can be gathered and used in immediate placement after extraction later. This is 2.7 by 8.5 drill. And this is 2.7 by 11.5 drill. Irrigate the drilled socket sufficiently to wash out the bone chips in the drill socket. Irrigation has dual functions of washing out the bone chips and cooling the area inside the socket to prevent bone heating. Execute profile drill at the speed of 100 RPM. More bone will be drilled out if profile drill is performed. Gather this and use it at the time of bone transplant. Use 3.0 by 8.5 and 3.0 by 11.5 drills. The most important issue is to always start drilling once the drill comes in contact with a bone at the depth of the drilling in the previous stage. After cooling, use profile drill for the 3.2 final drill. Bone chip will also be produced in this procedure. After having performed 3.2 by 10 drilling, final drilling will be carried out. Perform final drilling. .0 by 11.5 implant will now be placed. Turn UV on. Irradiate UV for 20 seconds. UV irradiation is completed. Once it is completed, take the implant out and place it. It is 4.0 by 11.5. Put the UV-treated implant in at the speed of 25 RPM. When I am placing the implant, I use machine up to the mid-length of the implant, but make sure to do wrenching with hand for the remaining length. This enables me to accurately assess whether I have reached the bottom of the drill hole I made. Since the offset is 9, I will place it up to the black line at the bottom. Being able to take it out this well implies that it has been placed by having drilled accurately. Abutment profile drill was used last to ensure that abutment is properly mounted. Then I will perform immediate placement after extraction for number 46. Insert the drill tube and drill vertically by using 2.0 by 7 drill. It can be deemed that the drill does not go in much since the tooth extraction socket is deep. The next is 8.5. Press slightly, and if it does not go in, drill up to 8.5 before drilling with 2.0 by 11.5 drill. If it is not possible to enter up to 2.0 by 11 because the mouth does not open well, then there is no particular need to do up to 2.0 by 11.5. You simply have to adjust the length properly with 2.7 drill. I am using the drill. It is 2.7 by 8.5. It is 2.7 by 11.5. Then I use 2.7 by 13 drill. You must drill by ensuring that the drill is inserted to the depth of the previous drilling. Then 3.0 drill needs to be used next. However, there is no need to use profile drill since it is tooth extraction socket. Therefore, I used 3.0 by 10 drill. Then I used 11.5 drill, followed by 3.0 by 13 drill. Now, use the 3.2 profile drill by putting even the offset. It is 3.0 by 10. It is 3.0 by 13 drill. 13 drill is used. Now it is 4.3 profile drill. It is the final drill. Execute 4.3 drill sequentially. You must remember that before you start drilling in each step, you must make sure that the drill is inserted all the way in to the depth of the previous hole before starting the engine. This will ensure highly accurate drilling. I completed up to the final drill. Then the guide will be taken out and bone will be transplanted. Mix the bone before and the autologous bone collected during drilling. And put it into the tooth extraction socket. Put sufficient bone into the tooth extraction socket. Put the bone in to ensure that there is no inadequate bone before inserting the guide and perform final drilling again to make hole for the insertion of the implant. Perform drilling with 4.3 by 11.5 final drill to ensure easy insertion by drilling the previously drilled location accurately. Irradiate UV onto the implant again. UV irradiation is completed. Make a hole for the insertion of implant Then, 5.0 by 11.5 implant needs to be inserted vertically in reference to the guide. Since it is a molar tooth, it is not possible to insert vertically as the handpiece touches the upper jaw. In such case, take the handpiece out and insert it slightly in vertical direction with hand. This will enable it to be inserted easily due to the depth of the tooth extraction socket. After inserting, place the implant by wrenching it to ensure that the bone remaining in the tooth extraction socket is engaged lastly with a wrench. Since the wrench is caught by the guide because it is too short, implant is being placed by inserting a stent. Since there is an offset, implant needs to be placed to the top portion of the offset. Implant is placed accurately by considering an offset. After placing, take the sleeve out. Being able to take it out this well implies that it had been placed accurately in proper direction. If the direction is deviated, there is a tendency of having difficulty in taking the connector out. However, there is no major difference. Then check whether bone particles have entered into the placed implant. Ensure that bone chip does not enter the implant through direct suction tip and confirm whether there is sufficient bone in the outer boundaries of the implant. Therefore, it was decided to mount bone-forming screw since the cavity is large. Mount the PRF made onto the bone-forming screw. Then the bone-forming screw and PRF over there will cover the soft tissue. Check whether inside the implant is visible through accurate suction and then mount inside the implant. Since the drill is too long, I change with a shorter one. Mounting is being done well. Check whether the initial fixation is achieved properly. There is sufficient initial fixation. Then, mount healing abutment onto number 45 to ensure PRF is inserted between the soft tissue and the bone-forming screw and suture number 46. I'm going to suture after tucking in the PRF under the gum. Since all the bone particles inside will be leaked out if the gum opens up, perform suture in the manner that prevents such opening of gum. It is a triangle suture by stitching on the opposite side on one side. I believe this triangle suture is highly efficient in suturing the relevant area after placing immediate placement after extraction. It is a highly effective and more useful suture method in gathering the gum than individual suture. Check presence of gaping gum and perform more sutures if necessary. Since it is suture that contains simply the tooth extraction socket rather than by performing additional incision, there is no problem that can be anticipated as you only need to perform suture in as-is condition. Healing abutment is put in the front and bone-forming screw is put in number 6 with suture performed. It is number 5 prior to the procedure and number 5 after the procedure. It is number 6 prior to the procedure and number 6 after the procedure. This is a photo after the procedure with completed bone implant in the tooth extraction socket side. Thank you.